Assalamu alaikum everyone. Jazakallah to Dr. Balagh for inviting me here today. It's wonderful to see so many people at a conference like this. Often it's me and a handful of people having conversations about issues like this, so it's wonderful to have such a large audience. I have a lot of material to cover and am going to be moving through my slides subliminally. So if there is not a coherence, then please do just bear with me. But what I'm going to do is keep this informal and chatty so we can talk in detail about the question that Dr. Rafaq put to us in this panel about the challenges and the questions that lie at the interface where Muslim patients and families interact with the healthcare system. And what I will do is focus on end-of-life care in order to be able to do this. What I want to do is contextualize the situation. So as somebody who likes numbers and is involved in public health work, I want to showcase work that was done by the Muslim Council of Britain a few years back, filtering through census data to try and illustrate the demographics of the Muslim population in the UK and particularly their health needs. So the first thing to understand is that as a community we are growing in number. We account for almost 5% of the population, which is almost 1 in 20. And in certain parts of the country, this will be much more, such as Bradford and Birmingham, and in other parts of the country, not so. Why is this important? When we're interacting with healthcare services, policymakers, people who are allocated resources, it's incredibly important for them to know what their population profile looks like and what the Muslim needs are in those particular areas. Given the rising population, what's concerning is our health indicators are poor in comparison to the national average. Women in particular over the age of 65 report higher levels of ill health compared to their national counterparts. So what we see is not just end-of-life care decision-making being a challenge here, but when we think about the healthcare context at large, there are inequalities in access to services and understanding of health needs that we do need to be aware of and be better at communicating and advocating in order for us to be serving our own community, but also being able to explain those needs to the people who are making these decisions. The other very important aspect of the demographic data is that although the population profile is relatively young, there is a significant proportion of the population that is aging. From the last census to the next census, the population over the age of 65 is scheduled to double. So that's a lot of people who are getting to the age where they will be suffering from comorbidities, chronic illnesses, therefore needing to make decisions and plans for that part of their life where they may be interacting with the healthcare service more or will be needing to be more proactive about their end-of-life care. So how best do we do this? So if you skip through, what I've been doing over the past couple of years is trying to grapple with this question of what end-of-life care decision-making looks like in the Muslim community, what works well currently, and what doesn't work so well. For the purpose of this conversation, I'm going to stick to more of the challenges and questions. And the reason for doing this piece of work is that there's very little work that's done in the UK context. Dr. Asim has done some amazing work in the States on this, but we're yet to get started in really trying to understand perspectives and needs of the Muslim community pertaining to end-of-life in the UK. So I've been speaking to stakeholders across the board, be that physicians, nurses, physios, psychiatrists, but also patients and families who are at that point in their life where they're having to negotiate end-of-life care decisions, and also chaplains and people out in the community, so scholars, bereavement staff, funeral services, whoever it is across the pathway of care who are involved in end-of-life decisions. That includes coroners, so anybody who's interested in knowing some of the conversations I've had with coroners and the sorts of challenges that they're currently facing in terms of how policy is moving in that direction, I'm happy to answer any questions. One of the things I've been focusing on in particular is the value shifts that we are seeing in families and in our communities. We see an intergenerational diversity in values when it comes to end-of-life care, caring for the elderly, caring for the terminally ill. So there are people who are reaching their end of life that may have expectations of being looked after. However, with the socio-demographic changes, the transition to nuclear families, both spouses having to work, often this results in families not necessarily living together, or even if they are living together, they may not necessarily be able to care for their elderly and their loved ones in the way that they would have liked to or would have predicted. These sorts of value transitions are therefore resulting in challenges and tensions when individuals and families are ending up in that healthcare context. So what I'll do is I'll share some of the perspectives of the stakeholders that I have spoken to. Some of the nursing staff that I've spoken to who work very closely with patients, particularly in the hospice setting or in the hospital setting, they talk about their perspective of understanding Muslim families and Muslim patients, and they say, what we find is that they're more together as families. We think often as healthcare professionals we're very, very important in that decision-making process. But in actual fact, when we interact with Muslim patients, when we consider their autonomy and their relational autonomy, there are a lot of different kinds of people who are involved in that decision-making. It's not just about us. It's about a lot of these different voices and different perspectives. So how do we ensure that we are able to do what is in the best interests of our patients? Often it's not feasible to have a direct conversation with the patient. Often there are English proficiency issues, which means that we need interpreters. When the family becomes a proxy interpreter, a family member, often this is essential if it means that the hospice staff or the nursing staff are able to get in the home. Having one stranger is challenging enough. Having multiple strangers can be problematic. So when the nurses have a family member interpreting for them, they say, I spend a few minutes explaining something, how we need to change certain medication, maybe negotiate pain relief, think about any artificial interventions. We spend a good few minutes doing that, and I turn to the family member and leave it to them to translate. And they say, either the English language is the most inefficient language, or there's something being lost in translation, because the time that the interpreter spends is usually just a few words or a few expressions. So what healthcare professionals say is that there is this challenge of them really being able to establish a rapport, a relationship, a trust with their patients. Some of that, of course, is dependent on patients relying on others to be involved in their decision-making process. But there are practical challenges there that do require further reflection. I think we've moved on a bit. The other sort of thing that a few of the stakeholders talk about is that what they find, even Muslim chaplains say this, that the Muslim community don't have as much trust in the healthcare system. And what I found in my research and my reading is that this isn't particular to Muslims. We have seen a decline in trust in the healthcare system despite autonomy and choice increasing. We see this inverse relationship between increased patient choice and trust in institutions and doctors in particular. So this is something very, very important when we think about communities who already have barriers to accessing healthcare services, who already have challenged relationships with institutions in countries like the UK. So this may help us understand why it is that they may not interact with end-of-life care services in a way that's predictable and expected. What this translates into when it comes to decision-making is particularly around advanced care planning, an initiative that is being promoted nationally as a way of best practice in end-of-life care, which is getting patients and families to think about repeated hospital admissions or terminal diagnosis in a proactive way, Muslim patients who don't ever see their GP or who don't ever interact with the healthcare service throughout their lifetime are going to be incredibly reticent to have such a personal, such a difficult conversation for the first time with a complete stranger. GPs say that these sorts of conversations often become a tick box exercise, often become very, very challenging. What this then results in practically is patients often end up in hospital inappropriately, there are repeated ambulance call-outs, they end up being discharged within 24 hours of admission. This creates an excessive resource burden on the system. We don't want to be getting people in and out of hospital in that way. It costs our health service. The other is that for the individual patients and families, this becomes an incredibly anxiety-ridden process. Families aren't supported to care for their loved ones when they are having increasing care needs, and healthcare professionals aren't really be able to negotiate how best to do this. So what I'm finding in the data is, as Professor Sachedina said, chaplains are becoming incredibly important in negotiating not just language proficiency issues, but religious knowledge and language. They carry an authority within this sort of dual role of spiritual and intellectual leadership that becomes very, very important in our healthcare setting. And I think will become even more so, particularly in the community setting. Although we think of chaplaincy purely in the hospital setting, when we think practically about being able to initiate and facilitate advanced care plans in the general practice setting, maybe what we need to start thinking about is bridging these sorts of conversations and involving chaplains in that community setting. What do I mean by this? So some of the chaplains who I speak to in hospitals, they tell me that families don't just expect them to provide spiritual support at the bedside, be that prayers, be that offering them some sort of meaning-making around the diagnosis and the illness, but what they also need is an interpretation of their religious values and their religious understanding. And some of this came up in the presentations earlier this morning. Within the Islamic ethical legal framework, it's one of the opinions is that it's only necessary for us to accept a medical intervention or pursue a medical intervention if it is incredibly likely or certain to have a benefit. So when we think about terminally ill conditions, when we think about experimental therapies, the burden isn't on the patient or the family to accept that sort of treatment. Now, chaplains say that families come to them with values like life is sacred or we ought to maintain life. How do we negotiate these opposing ethical, legal, and theological constructs? What we find at the lay population level is there is uncertainty about these values, and they expect chaplains to offer their knowledge, their linguistic understanding of the Islamic ethical legal framework in order to be able to interpret these values. In that healthcare setting, they're relying not only on that clinical expertise, but also this very deeply developed community-rooted religious expertise. Practically, if we then broker relationships between mosques, imams, as well as GP practices, what this can look like is a robust model of community chaplaincy that can help facilitate end-of-life care decisions in the community. How am I doing for time? 4 minutes, excellent. What I've been doing at the latter half of my research is doing outreach work with hospitals, hospices, people who are trying to adapt their healthcare services to make it more amenable to diverse communities. More and more, the healthcare service is recognizing that they are suffering from inequities and inequalities in access to the services that they provide. They are open to having conversations with the Muslim community. Unfortunately, we are not yet at the point where we are engaging with these sorts of conversations. So a mild plug to the sort of work that I'll be doing over the next few months. If there are imams, if there are chaplains in the audience, Mufti Zubair, let's try and get together to have a deeper think about what a robust model of Muslim community chaplaincy should look like. I've been having a conversation with one of the imams at Croydon. He has an outreach of 10,000 people every Friday at Jummah. That's a lot of people. That's a lot of people who we can start having conversations about what an Islamic model of advanced care planning should look like. What sorts of interventions should we be able to negotiate at the end of life? What should a pain ladder or a pain control ladder look like for a Muslim patient and for a Muslim family? I'll leave some of those questions for you. I'll end there because I could carry on talking about my research for a very, very long time. But Jazakallah so much for your attention.